Good afternoon, everyone, and welcome to Alleviate's webinar series. Today's topic is very, very important because most of our interventional practices, most of our pain practices, we have intervention plays a very important part. And what are the emergencies we encounter in our pain clinics? That's the topic for today. This is Dr. Wiquar Ahmed, consultant pain specialist at Alleviate Pain and Spine Center, Bangalore, former consultant anesthesiologist at Astradhar, Kolhapur. These are the clinics and our procedure rooms at Bangalore. So, introduction, emphasizing on strategies to decrease the risks, identifying the specific risks, considering alternatives. The true incidents, most of us, as we know, that there are minor complications which always happen and these go unreported. And that's also a reason why the true incidence of the complication is not feasible, because these all things go unreported many a times. So the overview of what we are going to be discussing about all the complications which could happen are based on these headings, and the American Society of Anesthesiologists for close claims. This is basically just a slide in which I'll be showing you because of the malpractices, the claims which happen and which are the procedures which are mainly rated high in those angles. And bleeding complications, infectious complications, very important is local anesthetic, systemic toxicity, very important part, even when we are doing, for all my anesthesia colleagues also who are playing, a part in pain now. It's very important aspect. Local anesthesia, systemic toxicity is quite a complication. Unintended destinations of the needle, vasovagal reactions or syncope, complications with intrathecal drug delivery. Again, these are the high-end ones where you can see that what are the complications which can arise with intrathecal drug delivery, opioid withdrawal, anaphylaxis, neural injuries, and particulate steroids. So this was the chart which I was speaking about, American Society of Anesthesiologists. They had done a study between 1980 and 2012, in which they jotted down all the procedures which were done and maximum claims for malpractice were done. The maximum claims supposedly happened for the cervical procedures. Again, we will be discussing about these things in detail when we will be delving, when we'll, about the vascular complications and all those things. And cervical non-neurolytic injections, that is your interlaminar epidural. Although we are still doing interlaminar epidural injections, it is the transforaminal injections because of the radicular arteries and the reinforcement arteries and all those. Maximum 27% of this claims were cervical non-neurolytic injections. Lumbar non-neurolytic injections come second, then the medication management, the devices. This is also because these procedures don't happen so very frequently. So infectious complication can cause meningitis or neural compression. Superficial and deep infections have been reported following epidural, your facet injections, your trigger point injections, which are given to the paraspinal muscles. In case of catheter, risk increases with the duration, for the duration of which the catheter has been inside. In case of spinal cord stimulator and intrathecal pumps, a rate of 5% was seen, whereas in experienced hand it was 1.8%, and in inexperienced hand it was about 13%. Post-procedural documents stating that you need to explain and counsel the patient of what to expect, and in any sort of complications which at some or the other point you are going to face in a pain practice. You need to actually tell your patients about the signs and the symptoms in which they have to pick up, and they get back to you at the earliest. So risk factors include diabetes, alcoholism, smoking, immunosuppression or compromised patients. Occlusive dressings, post-procedure antibiotics, and sterile precautions have reduced the risk significantly. A local extension and hematogenous spread can happen through the epidural space. The skin flora, that is your Staph aureus and epidermitis, these are the common ones which can be implicated in this. And MRSA high in implanted catheters. Epidural abscess patients initially present with back pain. Subsequently, they may develop radicular pain, then progress to motor and sensory deficit, accompanied by bowel and bladder involvement, and finally, paralysis. So, the patient who are presenting to you, 3/4 of them will have back pain, fever, about half of them, and neurodeficit in 1/3 of them. So this triad to exist in one patient at the same time is not possible. That is what this actually says. Rate of progression can be highly variable. They may have leukocytosis. ESR and CRP are quite elevated most of the times. Blood culture, always very important part is blood culture prior to starting your antibiotics. CSF analysis, although it shows protein and increased protein and pleocytosis in 3/4 of the patient, but doing a lumbar puncture may actually cause more harm in this case. So again, the cause of meningitis, spread of infection, and all this. So the choice of the choice for diagnosis will be your MRI with IV gadolinium study is the choice. In cases where MRI is contraindicated, you can get a CT myelography done, which is more invasive. But discitis and osteomyelitis on plain CT can be appreciated. Again, these are images of your axial and sagittal views with your T1 weighted image. Here you can anterior epidural space on the left side not appreciated so well, but again a T1 post infusion of gadolinium, you can appreciate significant amount of compression by an abscess. In these images, you can also make out the end plates. There is osteomyelitis as well. Coming to an important topic, local anesthetic systemic toxicity. Toxicity due to overdose, it can be because of overdose, intravascular injection, or unanticipated rapid absorption of the local anesthetic. So local anesthetics usually work by sodium, they bind to sodium channels and inhibit sodium permeability. Not only sodium, also potassium, NMDA, beta-adrenergic, and nicotinic acetylcholine receptors. Bupivacaine provokes QT prolongation. VT and VF also can happen in bupivacaine toxicity. Risk factors: extreme age, end organ dysfunction, pregnancy. See, one thing we should understand in pain is most of the times it's not overdose because the local anesthetic dose which you are going to use, the volume which you are going to use is not very high. The second option here is more likely, wherein you are injecting into the vessel. And the vascular spread also in intravenous as compared to intravenous, arterial is the one which causes problems. So again, risk factors: extreme age, end organ dysfunctions, your hepatic failures, your renal failure, and pregnancy. The threshold for seizures is affected by the route, the rate of injection, serum drug concentration, acidosis, and whether the patient is awake or anesthetized. So toxicity is more common with intravascular route. Intraarterial, the reason for that is because in intravenous route, it goes to the lungs and it is taken care significantly there. Intraarticular poses a higher risk even at a very small dose like 2.5 milligram of bupivacaine, can cause seizures. Lignocaine, it is CNS symptoms. Seizures are more prominent, and that these symptoms proceed before your cardiovascular symptoms. Initially, this cycle is very important. The initial phase, initially perioral numbness, metallic taste, rhinitis, restlessness, confusion are due to your inhibitory neuronal blockade. Sympathetic stimulation is also seen during this phase. So because of that, you will have your tachycardia and hypertension. In case sedation has been given, this phase could be missed. That is the reason why we told anesthetized patient and the patient who's awake and who's responsive and he's able to give you his inputs. This is followed by coma and respiratory arrest. In case of bupivacaine doses that are insufficient to provoke seizures, can cause cardiac arrhythmias. So the basic A rule is lignocaine affects your CNS first, bupivacaine is your CBS first. So this is a chart in which the severity of the symptoms are plotted against the plasma level of lignocaine. So it starts off with dizziness, rhinitis, nystagmus, dysphoria, shivering, then muscle twitching, somnolence, seizures, cardiac arrhythmias, and cardiovascular instability and collapse. So, how do you treat this local anesthetic toxicity? Local anesthesia, the infusion or the injection which you're giving, you need to stop it immediately. Oxygenation and airway management, you prepare immediately. Lorazepam, midazolam, thiopentol, propofol can be used to terminate your seizures. So vascular access, your crystalloids and your vasopressors, very important to have a good vascular access before you have done. No procedure is small. It's always better to have a IV line prior to any procedure, however small it might be. In case of cardiac arrest, ACL is initiated with epinephrine, 1 microgram per kg. Vasopressin is not recommended. 20% of lipid emulsion, about 1.5 ml per kg bolus, followed by 0.25 ml per kg per minute infusion for 30 to 60 minutes. Repeat bolus for persistent cardiovascular collapse. Infusion continued for 10 minutes after stabilization also. Once the hemodynamic stability has been achieved, still for another 10 minutes, you are going to continue the infusion. Lipid redirects the local anesthetic from heart and brain to your muscle and liver, where it can be excreted, removed out. In case of persistent cardiovascular collapse, in spite of all this, cardiopulmonary bypass can be life-saving. Coming to your bleeding complications, again, bleeding complications were more significant after August Baer. He had. I'm speaking on behalf of all your neuroxil procedures here. So it's not just the pain procedures. So he discovered in your 1860s, and after about 10 years, a decade later, epidural hematoma was first diagnosed with a person who had gone on neuraxial block. There was compression with that. And later on, also, it got worsened when your antiplatelet and your anticoagulants were discovered, wherein your heparin was discovered in your 1937 and your warfarin in 1941. After which the complications also increased further. So this is again a T2 weighted image in which you have got an axial and a sagittal view. So on MRI, you'll find a biconvex in the dorsal or the posterior epidural space. Here you can see from a thoracic to your cervical region, there is a biconvex which will be tapering at the ends. That is your hematoma will be seen. So next, coming to your and again for your once you have suspected and the patient has presented to you, in cases of bleeding, you get an MRI at the earliest. Neurological examination is a very important part, including your rectal examination, bowel and bladder. See for reflexes, there could be hyperreflexia as well, and pain with paralysis can also be there. So in a thorough neurological examination is very important in case you're suspecting any hematoma. Most of the times evacuation of the hematoma, but there have been still studies where which have got which have been conservatively treated. Whereas in cases of your abscess, it's always where it's seldom so that it gets cured without actually, especially in your deep abscesses. Superficial abscesses can be drained percutaneously, and coverage of your antibiotics, if still doesn't respond, then it can be proceeded for your surgical intervention. Unintended destination, intrathecal injection of local anesthetic can cause high spinal, respiratory arrest, high thoracic or cervical level of sensory or motor blockade. Most likely in cervical levels, also we use large volume most likely in cervical levels. Also, large volumes are used in your lumbar level as well. So flaccid paralysis, apnea, hypotension, bradycardia, your pupil dilation are common. Initial symptoms include lightheadedness, nausea, vomiting, air hunger due to intercostal activity, followed by phrenic nerve paralysis, apnea due to respiratory center involvement in brainstem. Blockade of cardioaxillary fibers at T1 to T4 of the medulla, resulting in bradycardia. Blockade of Edinger-Waspel nucleus produces pupillary dilation. In high spinal, you will be giving 100% oxygen. Intubation may be required. Bradycardia and hypotension treated with atropine, crystalloids, ephedrine, and epinephrine. Reassurance to the patient, because throughout this procedure, patient may not be able to breathe, but patient will be awake. So reassurance that this is just temporary, things will pass off, and angiolysis is also very important. This probably is the commonest of all your reactions. Vasovagal syncope. Syncope is the most common emergency encountered in pain clinics. Sir William Gowers first termed vasovagal in 1907. Pathogenesis is uncertain, results from venous pooling and reduced venous return. Vigorous contraction of heart chambers provoke basalt larysh reflex, resulting in paradoxical bradycardia and hypotension. At the onset, patients appear pale, diaphoretic, complaints of lightheadedness, nausea, and sweating. Myoclonic jerks can be accompanied, but they have to be differentiated with seizures, differentiated from seizures. In case vasovagal is encountered, the procedure should be stopped. The patient should be, if the patient is not in supine position, patient should be placed in supine position. Trials have shown crossing of legs and isometric exercises may help stop the progression, and most will resolve spontaneously. Cardiac monitoring, IV line with oxygen are necessary. Atropine can be given if bradycardia is there. From zero point 0.5 to 1 milligram can be used. Again, intrathecal drug deliveries, the complication associated with that, it could be due to withdrawal or overdose. In case of baclofen, withdrawal may particularly be fatal. Baclofen, as you know, baclofen is given for spasticity. So baclofen is an analog of inhibitory neurotransmitter GABA. Most common manifestation underdose are pruritus, return of spasticity, fever, tachycardia, hallucination, hyperreflexia, and if left untreated may cause rhabdomyolysis, brain injury, DIC, and death also. Presentation after 1 to 3 days of withdrawal. It may be due to exhaustion of drug reservoir and after a missing refill. So this is very important thing which could happen, that you have to fill, the refill has to be done of the pump. So if at all it has been skipped and there is no baclofen available in the pump, and in those cases also, if that is not the cause, then again you can inject catheter dye study to assess the integrity may be done. Oral and enteral administration up to 120 milligram in divided doses can be given. These alone are not sufficient. Continuous or intermittent infusion of diazepam, midazolam may be necessary. Propofol can be administered if the patient is intubated. In cases with hyperthermia, dantrolene can be administered. In contrast, overdose manifests as hypothermia, coma, seizures, artificial intubation, and artificial ventilation, immediately turning off the pump. Withdrawal of 30 to 40 ml of CSF via the catheter can be done. And physostigmine can be administered at a dose of 0.5 to 2 milligram IV over 5 to 10 minutes. May repeat after 10 to 30 minutes. Opioids are commonly used in our practices. So in this case, if they are given, and the final thing is, it has to be, you have to tell your patients to come for regular reviews. It might so happen that they get the relief, and if it is taken more opioid withdrawal, or if they are not, they have taken at a high dose and stopped suddenly. These symptoms can appear. Mainly seen in patient on intrathecal drug delivery, manifest as anxiety, insomnia, lacrimation, vomiting, diarrhea, and abdominal cramps. Treatment is resume opioid therapy in whom ongoing it's indicated. If the patient is unable to take orally, alternately you can IM or IV can be necessary or given. In cases opioid therapy is not indicated, clonidine can be started at zero point 0.1 to zero point 0.3 milligram orally every 6 to 8 hours, maximum of 1.2 milligram per day. Nausea, vomiting can be treated with metoclopramide, agitation with benzodiazepines. CDC advises, as I told you, that there should be a regular review from your patients. So prescription should be reviewed every 3 months at least. Anaphylaxis is an immune-mediated, and anaphylactoid reaction is non-immune, that is complement activation. Grades can be 1, 2, and 3. Grade 3 is where your oxygen saturation is less than 92%. The mean time between administration and collapse could be about just 5 minutes. Differentials, you have to differentiate from a panic attack, asthma attack, a vasovagal syncope. But in these cases, you will not be finding angioedema and bronchospasm. That is in panic attack and vasovagal syncope. Treatment could be high flow oxygen with intensive care, legs raised, IM epinephrine can be given. So 0.3 to 0.5, that is 1 is to 1000. So if no improvement, IV can be given, that is 0.1 milligram, that is 1 is to 10,000. Followed by, you can, an infusion can also be started 1 to 4 microgram per minute as needed. Aggressive fluid resuscitation also has to be done. Antihistamines, inhaled beta-adrenergic agents, albuterol with high dose corticosteroids can be administered early. Vasopressin in case it is not responsive for epinephrine. Atropine in cases of bradycardia. Glucagon in cases not responsive to epinephrine also can be given. Neural injuries and particulate steroids. Most of our procedures, we use particulate steroids. Let it be triamcinolone or your methylprednisolone. And that could be a cause if given intravascular as well. So in the cervical spine, the carotid and the vertebral arteries are in close proximity to the stellate ganglion, the cervical facets, and cervical foramina. The anterior spinal artery, which arises from the vertebral artery, receives the input from multiple radicular arteries and supplies the cord, the spinal cord, and principal supply of the cord. The posterior spinal artery supply posterior 1/3 of the cord. They are paired and are close to the dorsal roots. Very important, artery of Adams is the largest of the radicular arteries located commonly at T10 level on left side, but can be present anywhere between T10 to L2 in 17% even on the right side. The spinal arteries supply the cord but also accompany the the spinal arteries supply the cord but also accompany the roots. Ascending cervical and deep cervical arteries are also present. In some individuals, the radicular arteries are quite large in size and reinforce the anterior spinal artery. Radicular arteries supplying the spinal cord are termed as medullary arteries. If the reinforcing arteries are compromised with transforaminal injection at any of the cervical levels can result in infarction. Infarction of brainstem and portions of brain may result in stroke or even death. This is for the case of demonstration wherein for cervical epidural, transforaminal epidural injection, the needle has been placed. And you can see that there is anteriorly, there is a vertebral artery there, nerve root is there, and you can find a spinal segmental artery, which is again a branch coming from your deeper cervical arteries. And there is a radicular artery as well. The first report of complication attributed to cervical transforaminal injection, who died from spinal cord infarction. The location of infarction implied that radicular artery that reinforces the anterior spinal artery was compromised, but evidence was not offered at that time. Vertebral artery injection with stroke have been reported with posterior circulation compromise. Atlantoaxial joint, a fluoroscopic injection in which you can see that there is a filling defect on CT angio. You can see, and very close to the needle site. That's your atlantoaxial joint, followed because of which there has been an infarction. The exact mechanism is not determined. As analyzed by the MRI, the pattern strongly implicates that reinforcing arteries, spasm of the artery is inconsistent mechanism with vasodilatory effect. As there is vasodilatory effect of LA, so spasm is not consistent mechanism. Embolism of particulate steroid ranks as the leading cause, but direct evidence is lacking. Neurological complication of cervical transform epidural injections are catastrophic. That's the reason why cervical transforaminal injections are avoided or obsolete as of now. Spinal cord infarction is clinically indistinguishable from anterior spinal artery syndrome. That's Beck syndrome. Spinal cord infarction, abrupt onset of weakness, flaccid paralysis, areflexia, loss of pain and temperature perception. Position and vibratory sense will be intact. Preserved proprioception at the onset is associated with comparatively better outcomes. Spinal cord infarction is painful, radicular, or it could be back pain alone. Differentials include hematoma, mass lesion, abscess, or herniated large disc. When infarction suspected, immediate MRI should be taken. T2 weighted image at least after 4 hours. Pencil-like hyperintensities with cord enlargement will be seen. FDA clinical consideration for neuraxial injections. Cervical and lumbar interlaminar epidural steroid injections to be performed under fluoroscopy guidance. This is what we have, we pain physicians do. There is no scope for doing a blind, sitting cervical epidural like how it was previously done. Contrast medium under real-time fluoroscopy can be used prior to injection. Cervical interlaminar epidural steroid recommended at C7 to T1 level, not higher than C6, C7. Particulate steroid not to be used in cervical injections. Let it be cervical facet, medial branch, your atlantoaxial joints, or your interlaminar. And it's better to avoid your transforaminal and the cervical region. Moderate to heavy sedation should not be used. The patient should be speaking to you. So many things, many complications can be picked up or be prevented. Sterile face mask and gloves to be used. So the immediate treatment, no emergency management is known to reverse cord infection, unfortunately. Hypoxia and hypotension to be, it has to be corrected to actually avoid secondary injury. In cases of ischemic cerebrovascular accident, induced hypertension is advocated to maintain mean arterial pressure. No role of antiplatelets or anticoagulant therapy in spinal cord infarction. Thank you.